Hello, everyone, and welcome to Ortho NorCal webinar series. My name is Leah Rutinov. I'm the marketing coordinator at Ortho NorCal, and I'm honored to host this event together with Doctors Nathaniel Cohen and Michael Nuzzo, both orthopedic surgeons within Ortho NorCal. The presentations that physicians are about to present are intended for patient and healthcare professional education. If you have any questions, you can direct those to us using Q&A button on the bottom of your screen, and those will be answered after each presentation during our Q&A session. If you have any additional questions after the webinar, you can always email us at marketing@orthonorcal.com or call 408-412-8100. With all that being said, I'd like to introduce today's first panelist, Dr. Michael Nuzzo. Welcome, Dr. Nuzzo.
Thank you, Leah. We'll just go ahead and get started. So the subject today is of surgical management of massive rotator cuff tears, which essentially is just a very large rotator cuff tear. And so we'll just talk a little bit about what the rotator cuff is. The rotator cuff is a series of muscles and tendons that surround the shoulder that work together in opposite directions to keep the head of the shoulder centered in the socket. It provides a stable fulcrum for the shoulder motion and allows for a wide range of motion of the shoulder. There's three major muscles of the rotator cuff. The supraspinatus is the muscle on top up here, and that's the muscle that raises the shoulder overhead. The subscapularis is a muscle on the front of the shoulder that allows for internal rotation, and then the infraspinatus is the other muscle that allows for external rotation of the shoulder. So rotator cuff tears are generally clinically described by two separate categories: location or which tendon is torn, and whether the tear is partial or full thickness. So partial tears, we talk about those and how much a percentage of the tear, either high or low grade, or percentage. Generally, if it's more than 50% width, we start talking about more surgical interventions, and less than 50% more conservative treatment. So full thickness tears are complete tears, and that means the entire tendon is torn from the bone. And these are further subcategorized by the size of the tear: small, medium, and large. And then massive, which is the focus of today's talk, is greater than 5 centimeters, which means then you see the edge of the tendon here is retracted about 5 centimeters or more. Again, that's a massive rotator cuff tear. So in general, the symptoms of a rotator cuff tear is pain in the shoulder that radiates down the side of the arm. The pain that wakes people up at night is a hallmark of rotator cuff tears, is a common symptom. Some range of motion loss is also associated with it, and also weakness with reaching overhead. So the study of choice to diagnose a rotator cuff tear is a MRI. It's required to characterize the extent of the tear, to determine what size it is, whether small, medium, large, or massive. And it helps to guide surgical planning and clinical decision-making, especially when it comes to assessing the muscle atrophy, which is loss of the muscle mass of the rotator cuff muscle associated with the tendon tear. And muscle atrophy is an important component of clinical decision making, because severe muscle atrophy, it can be associated with less successful surgical outcomes. And here you see this is a cut on an MRI of the supraspinatus muscle in the fossa of the scapula. And this is just an example of what we look for when we talk about rotator cuff muscle atrophy, it being smaller, such as these here on the right. You're going to look at less successful outcomes with surgery. So treatment for partial tears is generally some pain medication like anti-inflammatory medications, like ibuprofen, physical therapy, occasional cortisone or PRP injections. And if the partial tear is larger than 50% or remains symptomatic despite the conservative measures we've tried, then surgery is an option. The treatment for full thickness tears or complete tears generally is surgical repair is recommended for most full thickness tears. And the main reason is when the tear occurs and you have retraction of the tendon back, it's not going to heal itself. That's one problem in the mechanics of the shoulder, and that's consequently why we do a lot of rotator cuff tear repairs, because they do not heal themselves. Most rotator cuff tear repairs are performed arthroscopically, which means it's done through small incisions in a camera. We use a series of suture anchors. You see one here on the bottom left. Most of them are made out of calcium triphosphate, so the anchors will dissolve. There's generally no metal used to repair the tendon. And on the right here, you see the anchors are attached to suture, and those sutures are then passed through the rotator cuff tendon and brought back down to the bone. Here's an example of a device we use in surgery. It's called a scorpion, to try to pass the suture through the tendon and ultimately end up with the construct you see on the right here. So the results of massive rotator cuff repairs, there are multiple studies of massive rotator cuff tears that were performed or repaired arthroscopically that show significant functional improvement in over 86% of patients. And actually the rotator cuff repair itself can change the atrophy on MRI. So arthroscopic rotator cuff repair is the first line of treatment for massive rotator cuff tears that don't have arthritis. Even with muscle atrophy and older age, functional outcomes can significantly improve with a repair. And this is an example of a massive rotator cuff tear repair and a patient that I performed surgery on. He was a 72-year-old male with a chronic massive rotator cuff tear. Down at the bottom here, you can see the edge of the tendon, which it should insert here, so it's retracted back by at least 5 centimeters. In this patient, there was some muscle atrophy. You can see here on the right, some muscle atrophy, but not extensive. And most importantly, the patient did not have any arthritis. His x-ray normal. And the patient was actually referred to me for a shoulder replacement, but we performed the repair. And here's a picture, some arthroscopic pictures. This is up here, the edge of the tendon, you see retracted back. This is the articular surface, so this should be covered here. Should not be able to see the articular surface from this view. It should be covered by the tendon. And just another picture of where the tendon should insert out here where it isn't. And one important component when we repair massive tears arthroscopically is tendon mobilization. Is the tendon pliable enough, the muscle pliable enough to allow us to stretch it back to its insertion, to allow a repair that's not under too much tension? And in this case, you can see we have a grasper and we're pulling the tendon back over, and we noted that it was a repairable type of tear. Here we're again passing sutures and suture anchors, and this is the end result of our repair. You can see as a 4 anchor repair, there's 2 anchors here and 2 more laterally that reinforces the repair. And then this patient went on to have uneventful recovery, and he did pretty well. And this is just a video of our repair after it was done, and we're rotating the shoulder just to show the different vantage. So, so what happens if you have a massive rotator cuff tear that's left untreated for many years? You develop something called rotator cuff arthropathy. And this is, if left untreated, massive rotator cuff tears eventually can lead to an arthritis. And the reason why is as you see on the right here, where the tendon should be is retracted back, so it allows for proximal migration of the head within the cup, which causes eccentric wear of the cartilage and eventually ends up in arthritis. And that's what this X-ray is depicting here. You can see osteophytes and migration. And this is an arthritic shoulder, and it as a result of a rotator cuff tear. And so that another name for that is called rotator cuff arthropathy. And this is the only surgical option when you have that clinical entity called reverse total shoulder replacement. Dr. Cohen's going to talk a little bit more about this in detail. But in general, it's a device that's placed, a prosthetic that's placed that kind of reverses the way that a natural shoulder is shaped, where the ball and the cup are reversed. And this increases the efficiency of the deltoid muscle to allow for shoulder elevation and compensates for the loss of the rotator cuff tendons. And this is just an example of one that I did a couple of weeks ago. This is a 62-year-old male with rotator cuff arthropathy. You can see the arthritis in there, and we performed a reverse shoulder replacement. So options for massive rotator cuff tear without arthritis, in general, repairs are by and large successful, not all, but many are successful, and a repair should be attempted and performed as long as there isn't significant or severe atrophy of the muscle. Massive rotator cuff tears with arthritis, again, also known as rotator cuff arthropathy. The only surgical option at that point is the reverse total shoulder arthroplasty. But what about a massive non-repairable tear without arthritis? In other words, there's a massive tear, but there's too much atrophy to repair it, or there's been prior attempts at repair that have failed, but there's still no arthritis in the joint. Well, a third option or a new option is called a arthroscopic superior capsular reconstruction, also known as ASCR. And here we're using a cadaver graft to recreate the superior capsule of the shoulder. And the intent here is to keep the humeral head reduced in the socket and to prevent the arthritis from occurring, or the rotator cuff arthropathy from occurring. And this procedure can improve pain and shoulder function. It can improve range of motion as well. So the indications for a superior capsular reconstruction is a non-repairable rotator cuff without evidence of glenohumeral joint arthritis. And this is an example where you can see migration, but there's no real osteophytes that have formed to indicate arthritis of the joint. And the case example, one I performed in a 59-year-old male with a chronic rotator cuff tear for over 4 years. There was significant atrophy. You can see here on this cut over here, this is the supraspinatus muscle and tendon. It's atrophied almost down to nothing. And so I knew that this stage, a repair would be unsuccessful. And so we discussed the reconstruction procedure with the patient. We elected to proceed. This is a video of the joint before the reconstruction. You can see that normally there would be a rotator cuff tendon here. It's not visible. It's retracted so far, and we're just looking at the joint without a tendon. So the procedure involves placing a human dermal allograft. You can see it here on the left. We pass it with a series of suture anchors. We measure the size that we need, and we cut the graft to size. And then this is all done arthroscopically or through a camera and small incisions. And this is the completed tear. So this is the graft, the skin graft that you see over top. And then here's a video showing the completed reconstruction. We're pushing up on the humeral head to show there's a reverse trampoline effect, which protects the cartilage of the humeral head and can prevent the arthritis from occurring. And so this is a relatively new procedure. It's been around for just over 5 years now. It was developed by a surgeon in Japan named Dr. Mahata. And there's several 5-year studies, outcome studies out recently that have showed restored function and high rates of successful return to sports and work with this procedure. So it's a very successful salvage procedure for a non-repairable massive rotator cuff tear. And that's all I have, Leah. Thank you.
Thank you, Dr. Nuzzo. We're now open to questions. If you have any, please use the chat or Q&A button on the bottom of your screen to send those over to us. I do have a couple of questions to start with. So the first question, why does the body not repair such an injury on itself?
Well, again, it has to do with the anatomy of the rotator cuff. When it is a complete tear, the muscle pulls the tendon off the bone and it sits over the cartilage. And for that reason, the tendon will never heal down to the cartilage. And so, as I said, consequently, we do a lot of repairs on rotator cuff tears because of the essentially the anatomy and the biomechanics of the shoulder and how it works.
Thank you, Dr. Nuzzo. The next question, if left untreated, does the injury get progressively worse?
If a massive rotator cuff tear is left untreated, yes, it often can develop into the arthritis we spoke about, or the rotator cuff arthropathy. And then once you get to that point where it's a more advanced stage, and the only option is a shoulder replacement.
Thank you, Dr. Nuzzo. Next question, what is the recovery time after surgery?
Well, for rotator cuff repairs and also the arthroscopic superior capsular reconstruction, patients will be in a sling for about 4 weeks. They'll begin some gentle range of motion exercises and begin physical therapy. Once 4 weeks is up, the sling will be removed and there'll be more active range of motion exercises performed. And in general, it's anywhere from 3 to 4 months of physical therapy before you start to have a full recovery.
Thank you, Dr. Nuzzo. The next question, how long will sling be required after RTC repair?
Every surgeon's different. I require it for 4 weeks. For larger, massive tears, up to 6 weeks. And the point of the sling is to immobilize the shoulder so it allows the tendon to heal back to the bone. It's provisionally held in place with the suture anchors that we spoke of, but you need time to allow the tendon to kneel to the bone.
Thank you. The next question, to identify RTC tears, do you order arthrogram?
I do not order an arthrogram. I don't feel that they assist me in diagnosing problems of the shoulder, although many, each have our own abilities about what we prefer when it comes to MRIs.
Thank you. Next question, what is typical recovery time for massive RTC surgery?
Well, again, it's I just answered that. So it's 4 weeks, 4 to 6 weeks in a sling, and then in general, 4 months, sometimes up to 6 months, depending on the size of the tear and the person, to a full recovery. And that's presuming that the tear heals. There's in general with massive rotator cuff tears about a 30% failure rate, and so we do try to repair them, but not all are successful.
Thank you, Dr. Nuzzo. Next question. I have a tear in anterior labrum and have been doing PT, but my range of motion is reducing. What would be your treatment plan?
Well, the labrum's a different structure. Labrum's like a gasket that surrounds the shoulder that stabilizes the shoulder, gives it support. When you have a tear in the labrum, more of the issue of the shoulder is instability. And so in general, we try to repair the labrum, especially in younger people, when it's there, to try to prevent the instability. So surgery, I think, may be an option.
Thank you, Dr. Nuzzo. Next question. Once you have the surgery, what is the best way to keep it in shape to avoid arthritis? And when do you know that you need a shoulder replacement?
Well, keeping the muscles around the shoulder strong, especially the periscapular muscles or around the shoulder blade, is important for the postoperative recovery. Keeping the deltoid muscle strong as well. So it's overhead presses, forward elevations, and latissimus pullback kind of exercises. And the second part of that question, how do you know when you need a shoulder replacement? That a lot of people just know. They have significant compromise to their quality of life. They can't sleep at night. They have difficulty even raising their arm up to the shoulder level. Lots of pain. So that's how you can kind of decide whether you want to proceed with that procedure.
Thank you, Dr. Nuzzo. The next question. If surgery is regarded as successful, what is the likelihood of re-injury after 1 year post-operative in high-strength sports like Olympic weightlifting?
Well, with Olympic weightlifting, it's going to be higher re-injury because of the forces across the tendon. Uh, in general, most people, there's the risk kind of goes back down to zeros. As long as the tendon heals to the bone, it's a pretty solid connection, and most patients get back to their normal level of sports and activities. And there's very low concern after a year that there would be a re-tear. But with super physiologic forces like Olympic weightlifting, that's going to strain the tendon a lot greater than most other activities. So you are definitely at a higher risk of re-tear with that kind of activity.
Thank you, Dr. Nuzzo. Next question. What do you do if the original repair fails? What is recovery rate after second procedure?
So yeah, revision rotator cuff tear repairs are often need to be performed for whatever reason. The tendon just doesn't heal. The size of the tendon, sometimes it has to do a lot with the vascularity of the tendon. Some rotator cuff tendons just don't have a great blood supply. And, there is, like I mentioned, in massive rotator cuff tears, a 30% failure rate. So we often do try to revise it. The revision decision is based off of the quality of the muscle, how much atrophy is there, what exactly went wrong with the first surgery. Was it just not healing, or was there some problems with the fixation failure? So there's a multitude of different decision points that to decide whether revision should be performed versus just going to a arthroscopic superior capsular reconstruction that we discussed at the end using a graft. And the other decision is there arthritis? If you have chronic tearing and an arthritic shoulder, then the surgical answer is a reverse shoulder replacement.
Thank you, Dr. Nuzzo. Next question. Are adhesions a big problem with a cuff repair?
Can you repeat that question?
Are adhesions a big problem with the cuff repair?
Adhesions, is that what you're
Uh-huh.
saying? Yeah, I'm probably talking about adhesive capsulitis. That is a complication of shoulder surgery, either in rotator cuff tear repairs or any shoulder surgery in general. It's a small percentage of people that develop frozen shoulder or adhesive capsulitis, and that it's unpredictable who and why, but some people do develop that. In general, most people can work through those adhesions and get back to full range of motion, but it tends to be a much longer rehab when you have a frozen shoulder after surgery.
Thank you, Dr. Nuzzo. Next question. Once fully recovered, are there any additional cautions one should be aware of with a repaired rotator cuff?
In general, no. I do not put restrictions on patients right around the four-month mark, I'll release patients completely to full activity, back to tennis, overhead sports, weightlifting, whatever you want to do at that point. Because I'm pretty confident that at that point in time, the tendon has healed. If it was going to heal, it would be healed by that time, and usually pretty solidly healed. So I don't have restrictions personally.
Thank you, Dr. Nuzzo. Next question. What structures are best to support the shoulder after RTC repair?
Can we repeat that again, Leah?
What structures are best to support the shoulder after RTC repair?
Well, I think the question is talking about what other muscles, and so focusing on the muscles around the shoulder blade of the scapula, the periscapular muscles, and the deltoid muscle, and that is exercises like forward elevations and latissimus pullbacks, overhead presses. So it's the other muscles around the rotator cuff that support it.
Thank you, Dr. Nuzzo. That's all for the questions today. Thanks for a great presentation. If you have any additional questions, feel free to email us at marketing@orthonorcal.com. We'd be happy to answer any additional questions. At this point, I'd like to introduce our second panelist, Dr. Nathaniel Cohen. Welcome, Dr. Cohen.
Thanks so much, Leah, and Dr. Nuzzo, fantastic talk. I'm going to follow up on what Dr. Nuzzo was talking about and talk about some of joint, when you do a joint replacement in the setting of rotator cuff tears. So let me just share my screen here. And we will start a slideshow here. Bear with me. So I'm going to talk about joint replacement options for large rotator cuff tears. And as Dr. Nuzzo was mentioning, rotator cuff tears are a very common problem. And it's been estimated that about a quarter of the population is affected. So we certainly don't treat all rotator cuff tears with surgery. Many tears are treated non-operatively, particularly those who are asymptomatic or partial tears. And smaller tears are treated with rotator cuff repair. There's a really high satisfaction rate with arthroscopic rotator cuff repairs. And this is really becoming our treatment of choice in 2020. Large and massive tears, the definition of this, as Dr. Nuzzo was saying, it's a tear that's greater than 5 centimeters in width or more tendon involvements. This is a supraspinatus tendon. The challenge on these is that these are often chronic and associated with fatty degeneration of the tendons. And these, as a result, can be quite challenging to treat. There's a high recurrence rate with repair. These can really be quite disabling. And some tears in and of themselves, when they get that large, can't be repaired. So the typical presentation is similar to other rotator cuff tears there, except these may be more severe. Loss of motion is a particular issue. And on MRI, what you'll see, and if you look at B, you've got an uncovering the humeral head. Here's the rotator cuff right here, and there's no tendon covering this. And then you look for degeneration. And so when you look on the what's called the sagittal or the side view, here's the tendon, but this has all been replaced by fat over here. So the treatment in terms of for larger tears, non-operatively, these are really geared towards symptom control and restoring motion. A lot of the time you can see patients who've got very large cuff tears who have outstanding motion and minimal pain. Physical therapy works well, and people can consider injections if you're really going with non-operative treatment. On patients who have traumatic tears or younger patients or those who have mild or no degeneration, that's when you really start to think about a repair. And again, you use suture anchors. These are made out of a variety of devices. They're sort of like molly bolts that have sutures attached to them. So the sort of what the algorithm for treatment at this point is an acute tear with new onset instability you'll fix. Chronic tears will often start with non-operative treatment with physical therapy, non-steroidal anti-inflammatories and injections. And if you have continued pain with non-operative treatment, if you've got a younger patient, and we're defining younger as under 60, you'll push to do a repair, either a partial repair, which can sometimes work quite well, a full repair if you can, a cleanup, which that's a debridement, or what Dr. Nuzzo was talking about with the superior capsule reconstruction. Now, if these don't work, that's when you start to consider joint replacement. So there's several different joint replacements that you can do. Historically, the hemiarthroplasty or the partial joint replacement, where you just replace the humeral head, has been used. And the indications now are pain with motion more than 90 degrees in a younger patient. There's several different types. There are ones that cover the humeral head a little bit more, ones that cover the humeral head a little bit less. That doesn't seem to play that much of a role in terms of pain relief. This doesn't restore motion, so, but it can provide pain relief, although the literature is somewhat unpredictable in this. It's a reasonable option if you have a young patient who's got good motion but still has pain from a massive cuff tear. The reverse shoulder arthroplasty was first described by the French in 1987, and it was first used in the United States in 2004. As Dr. Nuzzo was talking about, the initial treatment for this was for rotator cuff tear arthropathy. And this is essentially arthritis due to a massive rotator cuff tear. So what happens is that the rotator cuff serves as a dynamic stabilizer of the joint. And so it forces the ball down onto the center of the glenoid or the socket and allows the deltoid to elevate the arm. In a massive cuff tear, there's really no fulcrum to resist the movement of the humeral head, so it drives upwards. And this can lead to instability or loss of motion, which is referred to as pseudoparalysis. And the picture on the right, you have somebody with good motion on the right, on his left shoulder, and on the right shoulder, you can't move the arm, and that is referred to as pseudoparalysis. So what the reverse does is it allows for proper tensioning of the deltoid. So you can see on the in A, the humeral head is driving up, and you have laxity in the deltoid. As you tension the deltoid with a reverse, you can actually get range of motion, and this provides a stable fulcrum for the deltoid muscle to fire. And I just have a little, animation which allows you to see this. Once it engages at a certain point, then the rest of the muscles of the shoulder engage as well, the muscles of the shoulder blade, or what we call the periscapular muscles. And again, so the deltoid starts to fire and the periscapular muscles then take over. So a reverse shoulder replacement is generally performed in a hospital. It takes about 1 to 3 hours to do this. And typically people are in the hospital either overnight or a 1 to 2 day stay. Your arm's in a sling for about 6 weeks, and full recovery is estimated by about 6 months. So how we do this is we make an incision about 4 to 8 inches long in the front of the shoulder to receive the implant. The socket is prepared. You screw in essentially what we call a glenoid base plate, and then you put a ball, or the glenosphere, on the plate, and you attach it into place. The humerus is prepared. You put this actually into the arm, and then you have a cup that's placed on the humeral head. Then the humerus is popped back into place, and the soft tissues are closed. And once again, I have a small summary animation of what we do. So I'm going to just mute. So just turn down the music here a little bit here. What we do is we end up cutting the humeral head. And you can see once you remove the head, you've got this prepared. You use a little broach to open up the humeral canal. I apologize for the music in the background. We tried to edit this out. And then you take a trial stem and you put it into place. With the socket, You can often use specialized cutting, specialized drill guides. You drill into the socket, and then you make a little pilot hole. You ream the socket. You ream the socket to get a flat, to get a little flat portion here. Here we'll make a little drill hole, and then we'll implant our glenosphere into place. After we do some more drilling. There are a number of different screw options that you can use to secure your glenoid base plate. So and this allows the base plate to really be securely held in place, which you'll then secure with a few more screws. And once you have the base plate in place, then you put the glenosphere on, and then you go back to the humeral side, and you'll put in your actual stem, which presses up against the bone, and you put in your cup. You have a metal cup first, and then a plastic cup, and that gets reduced back onto the. So after surgery, your arm's placed in a sling. Initially, the first 6 weeks, we'll do very gentle range of motion, and we don't want active use of the shoulder. Most people are able to return to their normal activities of daily living within the first 2 weeks. And then driving usually waits about 6 weeks after surgery. And then they're depending on what you do in terms of returning to sports and exercise. Physical therapy is easily 50% of the success of this operation. Very gentle exercises will start initially, and you'll start with home exercises that really you have to be careful, you have to be diligent about following. And then generally we'll have people in a PT clinic working on this. So again, typically recovery time is about 3 to 6 months. When you look at the results, the initial results were published about a year after these were first approved for widespread use in the United States. There were significant improvements in pain, range of motion, and function, but there was a high complication rate. It was somewhere about 20%. And follow-up studies showed a decreased complication rate once there was a change in some of the designs of this. We continued gains in outcome with decreased complication rate, still on revisions and long-term follow-up, these benefits are maintained. Of course, no surgery comes without risks. The risks of any surgery, bleeding, infection, nerve injury. Some of the more severe complications that we see with this type of surgery are infection, dislocation, fracture, or failure of the glenoid component. So again, before you proceed with this, you should understand what the risks and benefits are before proceeding with any treatment option. Who should we not do these in? Deltoid function is really a critical part for a component for a well-functioning reverse. So any condition that affects proper deltoid function, such as an injury to the nerve that controls the deltoid, a deltoid injury, or certain cervical spine issues. We tend to not do this in patients under 60. And then if you have excellent result, we'll think of other treatment options such as repair or hemiarthroplasty. And then, of course, if there's an infection, you really don't want to use any sort of joint replacement. So in summary, massive cuff tears can be challenging but treatable. Repair is really your first line of treatment. Hemiarthroplasty can provide pain relief for patients with good range of motion. And the reverse shoulder arthroplasty is a predictable option to restore function in older patients with limited range of motion and a chronic tear. Thank you.
Thank you, Dr. Cohen. We're now open for Q&A session. If you have any questions, please use the chat or Q&A buttons on the bottom of your screen to send your questions over to us. I do have a couple of questions to start with. see. The first question, how safe is it to get a total shoulder replacement surgery during COVID-19?
So right now it's, if you'd asked me several weeks ago, I'd say it's very safe. Right now, the hospitals, at least in Santa Clara County, are holding on overnight stays in the hospital. And that's more to preserve hospital beds. In terms of the transmission, it's actually quite safe. Patients in the hospital are who have COVID are isolated, so you really don't. You're really not at risk in your hospital room. The ORs are incredibly clean. The staff is either using a mask or a mask and a protective barrier face shield. So, in all honesty, I think that you're at as high risk going to the grocery store, if not higher. And then people are tested regularly. So in terms of the issues with COVID, it's not that big an issue so far as I'm concerned. But the biggest question that we have to make sure of is there enough hospital bed space?
Thank you, Dr. Cohen. Next question. What is the average age for a shoulder replacement?
That's a really good question. And it depends on the shoulder replacement that we're doing. For arthritis, it's typically we're doing these on paper. For reverses, it may even be closer to 65 and above. And for shoulder replacements for arthritis, really it's people into their late 50s. It really sort of depends on how much its age is less of an importance. It's more important to focus on what your physiologic health is, if you have any underlying health conditions. Certainly we're not going to do this on patients who are in their 30s and unlikely in their 40s.
Thank you, Dr. Cohen. Next question. Dr. Cohen, great talk. What activities will I be able to return to following a total shoulder replacement surgery? Would I be able to play golf? Quality of life?
Great question. So, there's been a couple of very interesting studies focused more on taking all shoulder replacements, and what they found is that your preoperative level of activity is your biggest predictor postoperative level of activity. Play golf, certainly very. The reverse shoulder replacement tends to limit internal rotation, so you have a hard time bringing your arm behind your head. But again, for golf, that tends not to be such an issue. So certainly, if somebody wants to go return to powerlifting, for example, and I've had patients who've done that, who have had joint replacements, then you tend to use hemiarthroplasty rather than, for example, a reverse shoulder replacement.
Thank you, Dr. Cohen. Next question. Are you operating next brachial plexus? What nerves are potentially at risk?
Great question. So the brachial plexus sits, let me see if I can find a slide of the rotator cuff. So I'm going to pull up this slide here. And the brachial plexus sits on the outside, on the inside or the medial side of the coracoid process right here. So the brachial plexus sits around here and really down around here. You're operating primarily around here. The biggest risk that we worry about, there are two. One is the axillary nerve comes underneath, and it's something that we have to be careful about. There are reports in the literature of this, and then also the nerve that goes to the muscles of the short head of the biceps tendon, which are right over here. But if you retract them, it's a safe procedure. And if you stay on the bone on the socket, it is safe.
Thank you. Thank you, Dr. Cohen. Next question. How many total shoulder surgeries do you perform per year?
That's a good question. I perform a few a month, so somewhere between 25 and 50, I would say.
Thank you, Dr. Cohen. Next question. If you had multiple surgeries on your shoulder and are still experiencing severe pain, what type of procedure would you recommend? Should a total replacement be considered?
Great question. So if you've had multiple rotator cuff surgeries, I think the first question, if somebody comes in to my office with multiple surgeries, the first question that you want to make sure that I want to make sure that they don't have it, or that I want to make sure that we're not dealing with, is an infection, because some people who have mild chronic pain can still have an infection. So the first operation I would probably consider would be an arthroscopic biopsy, where you go and you take tissue so you can make sure that there's no infection. If there is no infection, then the question is what's the underlying issue. So if somebody has a rotator cuff tear and has just a re-tear, you can potentially fix that. If they've had a number of repairs and they've failed that, and there's a lot of tendon degeneration, that's when you start to think about doing shoulder replacements. And for that, the pain relief is very predictable.
Thank you, Dr. Cohen. Next question. Is there calculations involved in angling the correct position of the shoulder? Is it the same in all patients?
Great question. So you bring up a very controversial area of shoulder arthroplasty and shoulder replacements, which is the angle of the actual implant. So the initial design of the implant was done with a higher angle, but the center of rotation was kept fairly standard. The big issue with this, and if I go on, Leah, please tell me to stop. But the big issue with this is that the part right over here on the inside part of the socket would abut against the scapula bone and could cause some notching in it. And so more recent designs have focused on pushing on changing the angle and moving the center of rotation somewhat lateral to avoid notching, because it's felt the concern with if you get a lot of notching in the socket, you can sometimes you can wear the socket out. I hope that answers that question.
Thank you, Dr. Cohen. That's all for the questions for today. Thank you both, Dr. Cohen and Dr. Nuzzo, for the presentation. And I also would like to thank everyone for joining us today. We hope you enjoyed the webinar. Again, if you have any additional questions, feel free to email us at marketing@orthonorcal.com or give us a call at 408-412-8100. Enjoy your afternoon and have a great day. Thank you.